It's a privilege for me to speak to such interested and motivated doctors, telling such a story of a case at our place, the Armed Forces and the Military Complex at Bone Marrow Transplantation Unit. This case referred to us at April 2024 as a 30-year-old female with fatigue, CBC show leukocytosis and anemia, bone marrow aspirate and karyotyping show Philadelphia positive acute lymphoblastic leukemia. They started an affair protocol and imatinib. Then she went in complete remission, morphological complete remission. They shifted to dasatinib as she is intolerable to imatinib. And they did tush typing, show haplo with her sister, then referred to us for haploidentical hematopoietic stem cell transplantation. This is a brief summary of pre-referral history. When she came to us, we did donor-specific antibodies, and we found no antibodies in the recipient against the mismatched antigen in her donor, her sister. We did a laboratory assessment regarding pan cultures, complete metabolic panel, and it was accepted. And we go for radiological assessment and spirometry. They're also accepted. Normal spirometry and CT chest with ejection fraction nearly 70%. A pre-transplant disease assessment in morphological and molecular remission and pre-transplant chimerism was sent. Hematopoietic
question here, Dr. Assam. What is the MRD assessment that you use?
By multicolor flow cytometry.
So flow cytometry, not BCR-ABL, PCR, or next-gen sequencing?
No, it was by multicolor flow cytometry, and in the pre-referral history, they were not did PCR, and this will come later in the presentation.
Thank you.
Okay, see. Comorbidity index was 0 regarding the through or hematopoietic cell transplant comorbidity index, and the transplant conditioning intensity was 4. We use at our center fludarabine 160 milligram per square meter and busulfan oral 14 milligram per kilogram 4 days. The day of transplantation was in April 2024, as we see. CD34 was 8.5 million cells per kilogram, and GVHD prophylaxis, we give methotrexate 10 milligram per square meter day plus 2 and day plus 4, and post-transplant cyclophosphamide 30 milligram per kilogram day plus 3 and day plus 5, plus calcineurin inhibitor with cyclosporin with its trough level and mycophenolate motif, starting from day plus 6 to day plus 35. Post-haplo day 30 assessment, MRD by multicolor flow cytometry was negative, and chimerism was 100% for donor cells. At this time, we did BCR-ABL kinase domain mutation and show no mutation detected, and we sent the BCR for translocation 922, B190 and B210, and it was not detected. And it is preferred to do at the initial presentation, but it was not done. They only done karyotyping and show Philadelphia positive. Then came to us for transplant. Post-transplant at day 30, we did it on bone marrow sample, as we see. This is a brief summary of the case. She discharged at day plus 23, and we did our assessment at outpatient clinic, but unfortunately at day plus 35, she presented to us with fever and hematuria. At this time, no acute GVHD, and the CBC was normal. Cyclosporin level at day plus 35 was 150, and it was on a dose of 200 milligram pre-oral per day, and CMV assessment cytomegalovirus by PCR was positive, and we start valganciclovir. Hemorrhagic cystitis, at this case, it was in grade 2, macroscopic hematuria, not microscopic. We have our policy to deal with hemorrhagic cystitis case regarding preemptive and active therapy policy for this intractable complication. We have systemic therapy starting from oral fluids using hyperhydration and forced diuresis, discontinuation of low molecular weight heparin. We use tranexamic acid capron 50 milligram, 500 milligram IV, and we use prostaglandin E2 and leflunomide. If CMV positive, we use ganciclovir or valganciclovir, antimicrobials, whatever Cipro, and as appropriate per clinical or culture. We may use platelet agonists if platelet count is than 40, and the platelet transfusion if also platelet count is than 30. We may use Novo-7, recombinant factor 7 administration if INR more than 2, and we may use fresh frozen plasma. And this is for as a preemptive therapy if microscopic hematuria. But if clinical hematuria and at any time developed red urine, macroscopic hematuria with local interventions as continuous bladder irrigation with aluminum hydroxide, tranexamic acid, platelet, we may add Novo-7 or fresh frozen plasma. In this case, we use systemic and local treatment as regarding our policy to deal with hemorrhagic cystitis, and it persists, but it progressed to hemorrhagic cystitis grade 3. At this time, it's mandatory for us to go for cystoscopy, and for hematoma evacuation, this is at day plus 72, and it was intractable hemorrhagic cystitis. We did assessment for CMV by PCR. It was double negative 2 weeks apart, so we stopped anti-CMV treatment. It was valganciclovir. At this time, we did cystoscopy for hematoma evacuation. Now we are outside the box to deal with this case. You have any recommendation following this scenario? I want to hear your notes.
Any comments, Dr. Gaballa or Dr. Emmons, on this case so far?
Well, I guess there's several quick questions. The first one is, was the determination made that there was BK or adeno involved in the hemorrhagic cystitis, or was it presumed to be totally related to the cyclophosphamide?
Will come later, sir.
I see. And the CMV, you started therapy with a level of 156. Was the thought that the CMV was contributing to the hemorrhagic cystitis, or do you typically start therapy with such a low level?
We start treatment of CMV at this low level.
I see. How reliable are your CMV levels? I assume they are quite variable as we have in this country, or do you have, what is the methodology behind the level? Do you know? Is it a PCR? What is the technique for your CMV levels?
There is this from Dr. George.
Yes, actually, the more common for most of centers to start anti-CMV treatment when level above 1,000. If there is no acute GVHD associated with more and more aggressive immune suppressive, and if we have more than 500 with acute GVHD treatment, start anti-CMV. But this more comfortable if we can do CMV twice a week, but unfortunately we can't do it. We do actually once a week due to logistic resources. So if we have any detected level by PCR, actually we do it by PCR as your question. We start anti-CMV, especially if we have associated hemorrhagic cystitis that could be BK virus reactivation associated with CMV reactivation.
But forgive me for my ignorance, I'm not aware of CMV causing hemorrhagic cystitis. It causes certainly GI problems, including quite significant diarrhea. It causes suppression of blood counts. It can even occasionally cause problems with pneumonitis. very rarely, as opposed to HIV, does it cause retinitis, but I'm not aware of CMV causing hemorrhagic cystitis. That's something
No,
we're more familiar with BK and adenovirus causing.
actually,
Yes,
we
sir.
did start as the CMV cause of hemorrhagic cystitis, but this is our policy to start with any detected level with CMV, especially in haploidentical, not as a CMV cause of hemorrhagic cystitis. It could be BK associated with CMV, but actually we start with any elevated level or any detected level of CMV, especially in haploidentical transplant.
But sir, there was a fever and it was controlled on anti-CMV treatment, and we don't give it for hemorrhagic cystitis. We give it for fever, and pan cultures at this time was negative.
Culture.
So yeah, so you're saying we're treating the CMV, but we're not really correlating the CMV with hemorrhagic cystitis, correct?
Yeah.
Yeah. So another couple of comments. Honestly, the GVHD prophylaxis regimen as well as the conditioning regimen is a little bit different from what we practice. The haplotransplant, we try to use total body irradiation as part of the conditioning. I see you used Flubio-4 rather as an ablative Flubio-4. In haplotransplant, if we are not doing if we want to use an ablative conditioning, it would be more of a flu-TBI, so fludarabine with total body irradiation at a high dose. And then the GVHD prophylaxis of methotrexate 10 plus post-transplant Cytoxan plus cyclosporin as well as MMF is a quite an intense GVHD prophylaxis that was given as well. So there is significant amount of immune suppression. So I understand that the rise of viral infections here. Now, what I wanted to ask is, and I'm sorry if I missed it in your presentation, what was the CMV status of both donor and recipient?
CMV pre-transplant CMV
Yeah.
IgG, and for both donor and recipient was positive and IgM was negative. We didn't do it by PCR.
Got it. And do you not use as a standard the CMV prophylaxis?
No.
No, we didn't
Letermovir?
No, we didn't use CMV prophylaxis, but with any detected level of CMV, we start CMV treatment. But
Got it.
I'd like to answer your question because it could be some aggressive GVHD prophylaxis in context. It could be 4 drugs or 5 drugs actually. But because when we start a program of haploidentical, we start with 50 milligrams 2 days, and we face a lot of problem with hemorrhagic cystitis. Even it was terrible, and we start to decrease it up to 30 milligrams. Actually to 40, then to 30. So we try to use some T-cell lympholytic treatment in context of double of days of methotrexate. So to compensate those of cyclophosphamide decrease.
Dr. George,
أيوة.
let me ask about your strategy and management of the CMV. You are following the preemptive strategy, right?
Yes.
So what was the reading before this level?
Reading by PCR?
Yes.
No, actually, we haven't pre-transplant CMV PCR. We just go to
Even during the transplant, you are following the preemptive, and you are doing the PCR level of the once per week, right?
Right.
Once per week, yes, yeah.
So the reading before, you mean that this level is the first reading?
Yeah, you are right. It could be this is you mean this is, it could be the normal level of PCR of the patient before even transplant. It couldn't be CMV reactivation.
Yes, usually you are following a follow-up. When I see a rising tetra, I can start the treatment.
Yeah. You are right. Yeah, it's a good point. Yeah.
Okay.
But regarding the treatment of hemorrhagic cystitis, this time we end our policy for active treatment, and we asked her for cystectomy, but she refused to do cystectomy, psychological issues, or might be she didn't want to do cystectomy. So, following hematoma evacuation, we go for intravesical Novo-7 administration to stop the massive bleeding following hematoma evacuation. And we go for it as we stop IV fluids for 1 hour. Then we go for blood irrigation for half an hour. Then we give Novo-7 1 milligram divided in 3 doses on 30 centimeters of saline plus 25 milligram of capron in the renal bladder, and closed for half an hour. We go for IV fluids, return back for 1 hour, and open the catheter without irrigation, and repeat it 3 times a day using 1 ampoule of recombinant factor 7. At this time, the bleeding stopped and returned to microscopic hematuria only by the stick. At this time, we go for assessment at day plus 90. We found she in molecular remission, and we did PK virus. It's a case of late hemorrhagic cystitis, and we go for PK assessment, PK virus, the assessment by PCR. It was 2 million copy, and asked for to be repeated before starting treatment, and it came 6 million copy at the repetition.
Yeah, 2 questions, Sam, as before you keep going. Did you come up with the Novo-7 concoction? Did you make this up? Like, how did you come up with that? That's a very interesting cocktail you put together there, which you just described in intravesical.
Okay, sir. We go for intravesical Novo-7 administration in 4 cases.
Mm-hmm.
It give us strong results to be published later.
That's interesting. That's very interesting. Okay, so that's something that you have done on a small number of patients, has been successful. The next question is the PCR here. Is it in the blood or in urine?
PCR for BK?
Yeah.
Was an urine sample.
In urine. Okay. Got it.
Dr. Hassan, why you didn't check for the BK from the start?
It was on day 30, and we may see it's related to conditioning regimen. As in early hemorrhagic cystitis, we didn't think it's infection, but we delayed for this.
Yes, you are right. We delayed for this, but actually, when we start regular even irrigation or other modality, we try with her. We didn't have Cidovivir as a treatment for PK virus, but it was expected to make PK virus. So we wait until we got that treatment, or we have a way to get it, and we make it, because if we do it, we will face a problem without treatment. We will know we have a load of PK virus, but at this time we couldn't find a way to get Cidovir. But when we start to search with prolonged time, we found the source for Cidovir, so we try to got PK virus, because it was some the effect of facility for the treatment of PK virus. But you are right completely. We have to do it from day 30.
But sir, it was a challenge, as you remember, Dr. George, where to do the test, and when came positive. Can you give Cidovir? It was not available. It was a challenge at this time.
I just have an answer. This is a fact. We didn't do it because we haven't any solution for this problem.
But regarding it back to the case, Cidofovir was available to this patient. It came from America, and we give Cidofovir with we give propinicid 2 gram pre-oral 3 hours prior to each Cidofovir dose, and we go for a hydration 1 liter of normal saline before each Cidofovir dose. We give it as induction 5 milligram per kilogram over 1 hour once week for 2 weeks, and then maintenance 5 milligram per kilogram over 1 hour every 2 weeks. And we give propinicid 1 gram after Cidofovir by 2 hours, then by 8 hours. And the rest of Cidofovir ampoule diluted in 60 milli normal saline and instilled into the bladder for 1 hour. It was given as intravesical and intravenous. And this shows the result of BK assessment, BK virus assessment by PCR. At day plus 100, when we repeated, it became 6 million copy. And after following 1 month after treatment with Cidofovir, it was 4,000 copy. Then the case discharged with hemorrhagic cystitis 0, but later she developed the chronic GVHD, skin, oral, eye, pulmonary, and with good response to steroids. At day plus 180, we did the pelvic abdominal ultrasound. It showed bladder wall thickening 9 milli and clear content. Urine analysis, no abnormality detected, and disease assessment by multi-color flow cytometry MRD, it was negative. And this is our case. Our take-home message: collaborate and coordinate. If you change nothing will change. And thank you.
Okay, Dr. Hassan, is it eligible reduce the dose of immunosuppressive?
Excuse me, I can't hear.
He's asking if you have reduced the dose of immune suppressive as you are treating BK.
Yeah.
Yeah, sure. Yeah, sure. We start to decrease immune suppressive at this time was anti-BK virus. But what's the message need some to send? Actually, the patient from cystitis grade decreased from maybe 3 or 4 to 1 even before the starting of anti-BK virus. With a lot of modality, but the most efficient was intravesical Novosil. But actually, one of our way to deal with this patient was decreasing immune suppressive.
Okay, good. So what about the treatment of the chronic GVHD right now?
Please again, doctor.
What the treatment of the chronic GVHD at the moment?
When the patient develop chronic GVHD, what anti-chronic GVHD we use?
Yeah.
This is the
They
question.
respond to steroids. She
Steroid?
responded to steroids. We gave prednisolone 1 milli per kg, and she responded well.
But the patient already was on immunosuppressive, right?
No, at this time, I think so. She was stopped most. Maybe she was. Yes, I think so. Yeah, you can revise me, Assam.
She developed chronic GVHD later, following discharge by I think 1 month. She came with GVHD at day plus 130, and it was skin, oral, eye, and pulmonary, as I described. And this is her photo picture for her at skin GVHD.
So
and
by the time of the discharge, she was yes. So by the time of discharge, she was off immunosuppressive.
Yeah.
Yeah. And when she got this picture, you treated with steroids.
It was bad. Then this is following the steroid treatment.
Yes. Which the dose?
We give her only steroids. Prednisolone 1 milli per kilogram.
Yes. And then?
And then she responded well, so we taper it.
Okay, so she gave us a good response on steroids only.
On steroids only.
Okay, that's good.
Can I ask a question? So
We
a
have only
day plus.
we have only a message from this case about intravesical Novo7 administration. It show promising results. We have something outside the box.
Right. So there's several additional comments with regard to this case. The first one is that in this country, we essentially never use oral busulfan anymore. In the old days in the United States, oral busulfan, in addition to cyclophosphamide, was separately associated with incidence of hemorrhagic cystitis. We did in the United States previously, when giving oral busulfan, try to follow levels and adjust the oral busulfan accordingly to prevent very high spikes in the levels of busulfan, which separately are associated with VOD and other complications to the lung and the bladder. Do you have any capabilities, if you're continuing with oral busulfan, to look at levels of this drug to adjust?
Unfortunately, we couldn't detect the level, but at this patient, we try to go to some sort like reduced toxicity conditioning, and unfortunately, we prefer to use TPI, total nodal, total marrow radiation, but at this time we have a problem, technical problem with radiotherapy department to use it, but we didn't do level, unfortunately, and you have a good point because it could be toxic to some extent. Yeah.
Right. In addition to that, you began therapy for CMV at day 35. What happened to the blood counts of this patient during their period of toxic therapy for CMV? Did the platelet count fall?
Actually, we faced some drop for platelet and DLC, but it wasn't horrible because we just few 2 weeks, I can't remember actually, and we stopped it as regard it was negative, and it regain again and recovered, but it wasn't marked decrease in platelet.
I see. So the platelets did not fall to any range under 50,000. They were always above 100,000. Is that correct?
No, it didn't drop below 50.
Gotcha. So it was not felt that the platelet count issue contributed to the worsening bleeding.
Excuse me?
It was not felt that the platelet and blood count suppression was contributing to the worsening
Yes.
bladder bleeding over time.
Sure.
Gotcha. Okay.
It could be a cofactor for hemorrhagic cystitis, sure.
And what is your practice when giving post-transplant cyclophosphamide with regard to hydration management? And do you use Mesna as well as cyclophosphamide when using cyclophosphamide post-transplant?
Sure, we use Mesna. It's most probably 160% from the dose of cyclophosphamide with aggressive hydration, yes, with hyperhydration actually.
Gotcha. And you follow the output then of the urine closely during that period when they're on the cyclophosphamide?
Sure, yes.
And when do you stop the CellCept post-transplant?
About day 30 or 35. Yeah.
Gotcha.
35.
So the only immunosuppression this patient was on after day 35 was the tacrolimus, yes?
Yeah,
Cyclosporine.
actually, cyclosporin, yeah.
Cyclosporin, excuse me, yes.
Yeah.
And when was that decreased?
Actually, if we haven't any sign of acute GVHD, we start to decrease from day 60.
And that's what you did in this case?
I cannot remember. Some he can remember.
Yes, sir. We start to taper cyclosporin from day plus 65 as we think this might be an intense immune suppression during hemorrhagic cystitis episode. So we start tapering the immune suppression at day 65 with this case.
Gotcha. So, you know, the drug cidofovir has had a checkered history with regard its ability to suppress BK. It is used, but it's unclear how much it contributes really to the suppression of BK. Certainly, withdrawal of immunosuppression is more indicated to help with that issue. Dr. Hijazi already asked about the blood versus urine levels of BK. Was a blood level of the BK antigen ever determined, or was everything done in the urine?
No, it was only on urine. Urine sample.
see.
We didn't read it on blood sample.
I see. Yeah, we have not necessarily found as much correlation with the urine levels and specific organ system pathology as we have the blood levels of BK. And I wonder if there's anybody from infectious disease on who could talk more about that.
Yeah, that's I don't think we have ID, but that's what the infectious disease as well as microbiology team here, we diagnose with urine, but we monitor blood. So that when we are assessing response, we see how the blood is doing, unless there's a dissociation between the two. But for the most part, there's usually a good monitoring. As you know, the urine is more dramatic in its levels than the blood, and monitoring the disappearance. But I totally agree with what Dr. Emmons was stating. We don't really look at cidofovir as an effective therapy. And always infectious complications are going to be up on the list with hemorrhagic cystitis when we have utilized an intensive GVHD prophylaxis regimen. Now, looking at the future and refractory cases of BK hemorrhagic cystitis, what we don't have it here at the University of Louisville. I don't know if Dr. Gabala has it at Moffitt, but we send our patients who have refractory viral infections out to Cincinnati Children's. They have T-cell virus-specific T-cell therapy that is currently experimental, but in the number of patients we have sent, it has been quite effective in bringing down the viral load and treating them in a very effective way. And I don't know, Dr. Kabala, do you all have that, or do you also have the protocols that they are using in Cincinnati?
No, we don't. If there's a trial, sometimes they come and go, but as of right now, we don't.
So this was technology originally developed at Baylor through Helen Heslop, and they have a company now that does this in addition to the cells that we use from the Children's Hospital here at the University of Cincinnati. So I don't know, Dr. Gavola, if you have any knowledge of that aspect of things, but you might reach out to Dr. Heslop or her company to avail yourself if interested.
Yeah, no, we're familiar with it, and they were doing their initial work with the with the EBV, and then it extended to other things. It's certainly a very interesting and promising technology, but right now we don't have one of these trials.
Now, I see your message, Sam, in regards to the very interesting use of intravesical Novo-7 in combination with tranexamic acid and the procedure. In the case itself, I see the learning comes from the aspects of, haplotransplant and the way that we deal with them in terms of complications with their GVHD prophylaxis. We've gotten, maybe I don't know, I don't want to say like lucky, but like, the post-transplant Cytoxan hemorrhagic cystitis is a real thing, but there is more and more data of reducing the dose of the Cytoxan without having to add another agent like methotrexate here. Because methotrexate 10 IC, you give 2 doses instead of full 4. So you're kind of cutting the dose of the Cytoxan, cutting the dose of the methotrexate, or rather giving 2 doses instead of 4 of the methotrexate to compensate for a proper level of GVHD prophylaxis. But I don't know if it's half and half equals 1. Sometimes half and half might equals 4. But the interesting part here is there was a significant improvement of the bleeding with the use of the local therapy. And but in all honesty, I am not sure if the cidofovir did you a whole lot of benefit, right? Because the level was already lower before you started cidofovir. Isn't that right? It was on day 100, it was very high, and then 103 or 106, it was down to 6 million, and then it went from 6 million a month later to 4,000. Did I get that right?
The level of PK, dear doctor, it was 2 million, and repeated at the same time 6 million. Then following cidofovir, it was
Okay, so it's 2, not 20.
4,000. But I think cidofovir, it was not the magic treatment for this case.
Yes,
Yeah.
you are right completely. The main player, not as Cidofovir, actually, she improved as regard hemorrhagic cystitis, and with suppression stopping, immune suppression stopping, I think so. She made in bad need for Cidofovir at that time, because it actually she improved. But my comment actually, for immune suppression, we decrease the dose of methotrexate and cyclophosphamide to the half. A lot of data actually decrease dose of cyclophosphamide, and we try to follow it. But at we start to decrease it, we was very afraid to decrease without adding something. And actually, we have an abstract published in EHA 2024 for low dose, different comparison for different doses of cyclophosphamide, but with methotrexate. And we have an abstract when ASH reward in last ASH 2024 for the same CMV reactivation related to different doses of cyclophosphamide.
That's wonderful. That's wonderful. And also there is this regimen, but in our tumor board, I try not to talk about things that are might be crazy expensive, but there is a drug. I don't know if Dr. Gabala and Moffitt uses it a lot, but abatacept is being combined with a reduced dose of Cytoxan or cyclophosphamide, and a very reduced course of tacrolimus only. So abatacept, low-dose cyclophosphamide, or full-dose cyclophosphamide, they have both clinical trials. It's called a CAST, is the name of the combination, CAST. So CAST as in Cytoxan, abatacept, and short course of tacrolimus. And then there's that reduced CAST, which is a lower dose of cyclophosphamide with abatacept, and abatacept has been approved. We just never incorporated it in our standard here at the University of Louisville. Dr. Gabala, in your allotransplant program, are they using abatacept in the prophylaxis?
No, no, not to my knowledge. I mean, most of the cases are still done with, post-transplant cyclophosphamide. But I wanted to add something. Actually, I remember now. So for refractory cases of hemorrhagic cystitis that are obviously, not BK, not something that's treatable. If everything failed, I remember we had a case about 10 years ago where we used intravesical, formaldehyde, like formalin. And obviously that has some comorbidity. It would affect the bladder, but that's one case that I remember actually did control. But I think the use of Novo 7 here is very interesting, and I really haven't heard about it. So if you have a few cases, you probably may want to publish it as a case series.
But I would caution everybody with regard to the use of Novo 7 that for severe hemorrhagic cystitis, you may end up with severe clotting issues in the bladder that would limit the outflow of urine. I think in this case, you were fortunate in that the bleeding seemed to decrease with time. But if you have heavy amounts of bleeding and then completely inhibit the ability of the bladder to break down the clot, you're going to cause major problems with regard to urine flow and kidney shutdown. So that would be something I'd be very careful about using.
No, but my understanding is, and correct me if I'm wrong, is they basically, they had the patient going through the continuous bladder irrigation, and then they put it in, they left it for an hour, and then they continued. And I don't know if that was, if that's what they did, or, but I think they kept it in place for just 1 hour, and then they flushed it out afterwards. Is that correct?
Yes, this is correct. We just keep it Novo 7 for 1 hour, and then we continue continuous irrigation, as you said.
Exactly. Yeah. So if it's not gonna the clot is not gonna have time to organize and cause a major issue.
It could be the cause of not if we didn't face a lot of blood clots.
Okay.
This is a fascinating cocktail, actually. I might want to take the recipe from you and see how that goes. But but the reality is, I don't know if the pharmacy would let me do that. Put it in the bladder.
You sometimes, excuse me, you sometimes
okay, go ahead.
okay. We sometimes facing a problem not respond to anything because we use alum and formal. Yeah, we didn't use formalin or formaldehyde because we face a lot of comorbidity actually because this lady facing later a neurogenic bladder. And I think if we use something like formaldehyde, she will complain urinary bladder problem for life. So we try to use something less invasive, but it could be facing a lot of problem. We didn't do just 4 cases, but if we increase it, we may face a lot of problem like blood clot, as you said. But I'm sorry to interrupt you. You can take a phone.
Okay, because I was disconnected for a while, because I want to go back to the boss side. Acute practice, Dr. Hijazi and the colleagues. What is the ideal dose right now and the frequency?
Well, I'll tell you, no one knows because the standard for using it is everybody's going with how progress was done with 50, but our program here is moving down on the dose and trying to find any reason, but without addition of immune suppression. So our standards PTCy plus TEC and CellCept, and the PTCy dose, the goal is that we're have it in a consensus meeting to be reduced to 40 without the addition of other immune suppression.
For 1 day or 2 days?
T+3 and 4, so 2 days.
And
yeah, I know the Europeans do it a little different, but we do T+3 and 4 and start tacrolimus and MMF on T+5.
Okay, and did you start to use it for the fully matched?
We use post-transplant Cy across the board. Matched sibling, unrelated, haplo, mismatched, unrelated, everyone.
Yeah.
The only thing that we don't use post-transplant Cy for is for those regimens for aplastic anemia that has methotrexate in it. So we then just leave the methotrexate only.
Okay.
Also, cord blood transplant. That's the only other issue.
Yeah, if we do them. Yeah.
Yeah.
My question, okay, if we have a case of aplastic anemia with haploidentical, use both sides without methotrexate. What I got, if I'm wrong, correct me. You mean in matched related or matched unrelated, you use methotrexate, but in haplo, what did you do?
In haplo, we use marrow. So that's our first prevention of GVHD and aplastic anemia is we use marrow instead of peripheral stem cells. That's number one. And then number two, in haplo, we use PTCy and TAC and I'm sorry, with cyclosporin and mycophenolate. But in this case, in haplo, what we do is we would keep the immune suppression much longer than our standard for or any other indication. So I don't start tapering until 9 months after allotransplant immune suppression.
Okay, but you use both sides as regular in aplastic.
Right. We don't do a whole lot of in aplastic anemia in general. So for that reason, not a whole lot of haplos. We're able to find matched unrelated donors quite a bit. So the majority of the transplants that we do is matched unrelated rather than match related or haplos. But yes, in that and that's the what I recall in the last haplo that I did was we used PTCy and TAC cell sept post-transplant, but the TAC stayed for quite a bit.
The largest series of these patients who have had haplotransplant for aplastic anemia is from Johns Hopkins, and that's well published, and they use post-transplant cyclophosphamide. I would say in terms of the bang for the buck economically, in terms of the overall transplant here, investing in IV busulfan over oral busulfan might be more important in overall outcomes for your patients than abatacept or other more expensive things post-transplant.
Yeah, sure.
I think we use abatacept for I think 2 years. 2 years we use abatacept Orencia. Remember, Dr. George?
Yes, but it was in pediatric and then benign.
I put a link to a publication from the University of Miami that was using intravascular activated factor 7 and aminocaproic acid to stop bleeding in hemorrhagic cystitis. So that's at least one thing from this country to add to the discussion.
What about radiographic embolization of the cystic artery for intractable bleeding?
It can be done, but it's very morbid. You'll potentially cause necrosis of the bladder and worsening bleeding potentially. And it causes great scarring after that. And patients often then have to have either reconstructed bladder or alternate, ways of managing urine thereafter.
Dr. Manar, I saw you asked a question about maintenance therapy post-allo, since this was a Philly positive ALL. Is that something that you utilize, Dr. Assam? We can't hear you if you're speaking, but the question is regarding maintenance therapy post-allo transplant for Philly positive ALL.
Our maintenance therapy post-transplant?
Yes.
Yep.
Regarding this case, we go for TKI, we give dasatinib, and we planned to go for 2 years. She is still on dasatinib.
Got it.
Only, dasatinib only.
Got it. Yeah.
So
So far,
when was
go ahead, Doctor.
dasatinib? Sorry.
Dr. Emmons, go ahead.
Sorry. When was dasatinib started post-transplant?
I think so beyond day 100 in this case, because she has a lot of complication and fluctuating blood count, as I can remember. Some, you can correct me.
Yes, Dr. George started day 125 and still on it till now.
Gotcha. I'm impressed that chronic graft versus host disease in a haplotransplant patient of the skin, mouth, eye, and lung responded only to steroids. I don't think I've ever seen that from a haplotransplant patient. Usually those patients require more intensive interventions. Typically, we're adding at least other drugs beyond steroids. I think that's remarkable that this patient seemed to have that much GVH that responded to steroids only after a haplotransplant with accelerated withdrawal of tacrolimus, or cyclosporin rather.
Sir, GVHD comes following tapering the immune suppression, but when it comes back and we give steroids again and respond well.
What was the basis on which the judgment was made that this was pulmonary graft versus host disease?
It was a radiological assessment. We didn't go for PAL or anything or biopsy. We go for only radiological assessment.
And was it Sika syndrome of the eyes and mouth involvement, or more than that?
Yes.
And all of these things completely went away with steroids only. Is that correct?
Yeah.
Yes, fortunately, she responded well. It could be not an regular to happen, but what happened actually with this lady. But my question, any center start to treatment, either chronic or acute GVHD, if it is aggressive, start with dual anti-acute GVHD in context of steroid and JAK2 inhibitor?
Yeah.
What I mean, you expected she didn't. She don't respond to steroid alone. In some cases, you start steroid in combination with JAK inhibitor from the start.
So that's actually a clinical trial that is ongoing right now, using JAK inhibitor upfront with steroids with the hope of trying to spare patients off of steroids faster because of the long-term effects of steroids. However, generally speaking, when we have a patient developing multi-organ chronic GVHD involvement, as we start the steroids is always when we are already preparing for adding ruxolitinib to try to bring the disease down and bring the steroid dose down. Now, we do know that ruxolitinib is not a great drug for lungs. Lungs don't have really good therapy in the frontline setting. We do think that belumosudil and axatilimab are better lung GVHD drugs, as they are better with sclerotic fibrotic changes from chronic GVHD. And we try to use those rather than Jakafi when we see that the lungs are not getting any better. And the data is there. It's subgroup analyses from the same trials that got the drugs approved, that they looked at the response rates within lungs. Because as you know, lung GVHD is a tough one. It's not that easy to improve from, because of the nature of the lung tissue itself. However, looking at these, that is a clinical trial in progress that they are using combination steroids and ruxolitinib, and even including ruxolitinib, they're trying to use it even in a preventive measure now and add it to the frontline without steroids as an attempt to control the disease right away and not wait, and try to spare patients from steroids. Of course, pharmaceutical sponsored studies are plagued with what pharmaceutical sponsored studies would be, which is, putting trials to serve their agent in that disease. So there is also ruxolitinib plus axatilimab as a combination therapy in an attempt, which is Incyte, the company that makes these drugs, are putting them, trying to basically control the market that way. But that's my answer to your question. I don't know if Dr. Emmons and Dr. Gabala would like to also chime in on the use of alternative agents in the frontline setting of chronic GVHD.
Yeah, it depends on the severity of the GVH. Typically, our typical practice is to try steroids for at least a week up front, and then depending on the severity and the number of organ systems involved, make decisions about the addition of other drugs, including the JAK inhibitors and others, moving up the scale. But again, this is a very remarkable case in which you seem to have multi-system involvement, and it responded to 1 milligram per kilogram of steroids. That would be very, very unusual for a haplotransplant in our practice, but I'm glad the patient responded as well as she did. Could I bring up 2 other just quick questions for the group?
Yes, please go ahead.
There is an initiative on the part of ASCO, our main clinical organization, for outreach. And I know that as of June, when the ASCO meeting took place, there was an agreement signed, including the Egyptian Cancer Society, for greater involvement in terms of improving quality of programs. And I wondered if that has made any difference at your institution with regard to any outreach or abilities to do things. Are any of you on the Egyptian side aware of this, and has it made any difference? I put the link in the chat for those who are unfamiliar with this.
Actually, I have Dr. What's his name? He was one of in the meeting of the ASCO, and
thank you so much for bringing this. I appreciate this. Is very helpful discussion that I've been hearing. I learned a lot. One of the things that what you just brought up. So we were with Dr. Al Ghazali from Egypt. I myself work at Baylor here as a breast medical oncologist. But I was involved with few other Egyptian oncologists in that meeting, and essentially it is a very good opportunity to open the door for essentially all the ASCO grants, including the most important grant, I would always say, the IDEA grant, which would allow people from international collaborative societies to work in as a postdoc, essentially, for like a short term of time, sponsored by ASCO. But also all this, ASCO Career Development Awards, Young Investigator Awards, and even volunteerism. So as someone who about 50 ASCO points so far, so hopefully like midway. But that also opens up the way to kind of get all of these volunteerism points in. So yes, it's a great opportunity, and I think that it can enhance education through work and on curriculum development. I believe that this is one of the better ways for it to be adapted.
That's excellent.
I'm sorry.
I'm glad you're taking advantage of it. That's super. I also put the link for what ASH is doing for international outreach. Their initiative is to essentially make free of charge all of their programmatic materials. So anybody who's not aware of that on the Egyptian side should certainly take advantage of that as well.
Yeah, that's great. Thank you so much. And I apologize, but thank you for giving me the platform to add that one-liner, because I think that this is a very important opportunity indeed. Thank you.
Yeah, I also I have my friend I asked about the clinical trial. I know Dr. Emmons has been putting this every tumor board about ability of doing clinical trials in Egypt. Actually, yeah, there has been a lot that has been started 2022, and there are multiple clinical research companies that are acting with the pharmaceutical companies to facilitate this kind of work. Like physician doesn't have to do anything. So there is a company that works with you choose if you wanna, for example, you wanna put a clinical trial to Egypt, we can let them know, and then they will reach out to the pharmaceutical companies to do the IRBs, to do all the paperwork in Egypt, and use, for example, Al Maadi Hospital as a site for the clinical trial, or Al Mansoura Cancer Center as a site for clinical trial. He is willing to do that and help us with that. If anyone interested in a clinical trial, I can give him the information, and he will reach out to the pharmaceutical company to see if they can have Egypt as a site for the clinical trial.
That's wonderful news. As we had discussed at the last one of these, some of these drugs are unavailable in Egypt. So clinical trials are the way to bring those treatments to Egypt, which is wonderful to hear.
Yeah, we'll try to do that, but this will need an initiative from attendings in Egypt, who are in the hospital, to reach out. They can reach out to me, or I can connect them with the company to discuss what kind of clinical trial they are interested in, because the company cannot just go ask the pharmaceutical company without knowing the need for this drug. And there is a lot of
Dr. Mustafa, they are willing to share in any clinical trial until, as you know, they have a very good infrastructure to be able to participate in clinical trials. And then please, I can give you your telephone number of how I can reach you to discuss this issue.
Yeah, I put my text, my number. Can reach out to me and my email on WhatsApp or my email. But they do everything. You will recruit the patient. That's all. Okay. They have clinical research coordinator. They have everything. CROs, yeah. They act as a CRO. Yeah.
Okay. Good.
So and if you search, there is something called Hayat al-Dawa al-Masri in Egypt, which is controlling all the drugs in Egypt, like the FDA for Egypt. They have lists. We have ongoing 40 clinical trials in Egypt right now.
Okay, Dr. Mustafa, I have to get your phone number.
Yes, I'm putting it once again.
Send it to you, Dr. Mohammed.
You can text me on WhatsApp, my email. Yeah, I think there's, and he's willing like to give us like a presentation on that if you wanna have a Zoom meeting with him. And for this company, even like the CEO, she is a heme oncologist from Zagazig University, but she's a children, like she's pediatric oncologist. So there is a lot of drug, like for chemotherapies, they have chemotherapy trials, not chemotherapy, I mean immunotherapy trials. They have some like IBD trials for new drugs. So I think it's good.
Okay.
Did you
Dr.
have my
Mustafa.
number?
Yeah, yeah.
Okay. Okay. Any questions? Okay. I think that's it for today. Thank you everyone for attending. Looking forward for our next tumor board.
Thank you. Thank you very much,
Thank you.
Dr. Mustafa, Dr.
Actually, it
Assam, and
was
all the attendees.
very
Pleasure.
fruitful.
Thank you so
Thank
much.
you, everybody, and good night.
Thank you very
Thank you.
much.
Good night.
Okay, goodbye.
Thanks. Bye.